I actually discuss in a very brief fashion a topic that we haven't discussed previously. It's a little bit of hematology. Because of data just presented at the European Hematology meeting that occurred virtually just a little while ago, just after ASCO. So we thought we would talk a little bit about, second generation BTK inhibitors in the setting of CLL. Some of you may be aware that in the past, first of all, CLL, some patients have it, they don't need therapy. A lot of patients do need therapy because of the volume of cells and the infiltration of the cells. And in the past, when therapy was decided, it was a lot of alkylator-based therapy. Then we had, CD20 inhibition. Then we had the first generation BTK inhibitor with ibrutinib, which really changed patient management. But then now we have some second generation BTK inhibitors. And the one to discuss with you because of new data, and this was actually a late-breaking abstract for the EHA meeting, were the data that were discussed in a study, in the global phase 3 study that compared zanubrutinib versus ibrutinib. So it's a head-to-head comparison of two different BTK inhibitors in more than 600 patients. It just kicked me out. I only see Joel's name, which is good on my computer. So I'm going to hope. What do you guys see on your computer? You see the slides still? Oh, here, thank you. If not, we're gonna keep going from memory. So thank you very much. So, zanubrutinib given twice daily, 160 milligrams twice daily versus ibrutinib 420 milligrams one daily. And this is for patients who had one prior systemic therapy for chronic lymphocytic leukemia or small lymphocytic leukemia. And I've noticed that in this study, they had about 20% of the population of patients with poor prognosis based on the biology with deletion or 17p deletion and or a p53 mutation. So what we have here are data from the interim analysis at 12 months and a total median patient follow-up of 15 months. Let's go to the next slide. Essentially, what we will see on the next slide is the information related to the primary endpoint that includes overall response rate by investigator assessment. And this was significantly higher in the zanubrutinib arm versus the ibrutinib arm. You see the number 78 versus 62% with p-value of 0.006. Then there was an analysis also in terms of the evaluation by lymphocytosis patients. You see the overall response over there. And for the poor prognosis subset of patients, which accounted for 50 patients, zanubrutinib led to improved response rate 83% versus 54% for ibrutinib. Overall, the PFS rate benefited patients who received the second generation BTK inhibitor, 95% versus 84%. And at this time, the overall survival is not statistically different. More time is required for follow-up, which is not unexpected in a study that has 15-month median follow-up in the setting of progressive CLL. But in addition I'm seeing back Joel's name, but in addition to the improved outcome that was observed in terms of response rate in the study, there was also a benefit observed in terms of safety on this particular study, particularly in the area of the number of patients who experience grade 3 adverse events or worse. Including atrial fibrillation, you see the number of lower patients with atrial fibrillation and flutter. It was 2.5% for the newer agent versus 10% for ibrutinib. And also there were lower rates of other cardiac events. Next slide. So in addition to, looking at the CLL data, we thought also to include some additional data that have been generated with zanubrutinib in another trial that is called the Sequoia trial. And this was a randomized trial, but there's a cohort that was kind of a phase 2. The cohort 2 was a phase 2. looking at the subset of patients with the poor biological findings, such as as I mentioned before, deletion or of 17p, so the short arm of chromosome 17, and that presented at the ASH meeting. And again, in this particular group of patients, there were 109 patients, and the 18-month progression-free survival was 91%. The 18-month overall survival rate was 95%. And then we wanted to also put that in perspective, not only this the European hematology presentation comparing those two BTK inhibitors head to head, but also share with you the data that were presented at ASCO of the Elevate RR trial. And that was also another head-to-head comparison in this particular case of another BTK inhibitor, acalabrutinib, versus ibrutinib in this particular set of patients, again, with CLL who have deletion of the short arm of chromosome 17 or the long arm of chromosome 11. And in this particular comparator trial, there was non-inferiority between these two BTK inhibitors. So a little bbit different than that was observed in the trial that I presented comparing zanubrutinib versus ibrutinib. And although we don't have slides because, again, of time, they had also been a comparison in Waldenstrom's macroglobulinemia of zanubrutinib versus ibrutinib, showing favorable data for the second generation BTK inhibitor. So again, this is a little out of the classic solid tumors, but we thought, this was really late-breaking information in hematology that we thought would be very interesting for you to have for practices. The zanubrutinib has not received approval yet by the FDA. It's approved for refractory mantle cell, but we thought this would be of interest again. And that's it for hematology.